guidelines of the European Society of Hypertension and the European Society of Cardiology, which were published before the JNCA document, agree with the JNCA document that in the elderly, the strong evidence is to treat individuals with a systolic blood pressure equal or above 160 millimeter mercury, because all trials have dealt with these patients. And then to go below 150 millimeter mercury, to be more precise, between 140 and 150 millimeter mercury, because again, the evidence from trials is that this is the range of values for which the beneficial effects have been documented. The European guidelines, however, also mention the possibility, which is scientifically less strongly based, of being a little bit more aggressive, that is to treat patients with grade 1 hypertension, that is with the systolic blood pressure between 140 and 159 millimeter mercury, and to go below 140 millimeter mercury also in the elderly if treatment is well tolerated. The reason for being less strongly recommended is that post-hoc data are only available and not data from randomized trials. One problem in giving priority to some combinations with respect to the others is that randomized clinical trials, except one or two examples, have only used randomization for the first drug, not combination. We had a couple of exceptions, but in most instances this was the case. So what was done in the European guidelines? The guidelines of the European Society of Hypertension and the European Society of Cardiology, which were published before the JNCA document, agree with the JNCA document that in the elderly, the strong evidence is to treat individuals with a systolic blood pressure equal or above 160 millimeter mercury, because all trials have dealt with these patients. And then to go below 150 millimeter mercury, to be more precise, between 140 and 150 millimeter mercury, because again, the evidence from trials is that this is the range of values for which the beneficial effects have been documented. The European guidelines, however, also mention the possibility, which is scientifically less strongly based, of being a little bit more aggressive, that is to treat patients with grade 1 hypertension, that is with the systolic blood pressure between 140 and 159 millimeter mercury, and to go below 140 millimeter mercury also in the elderly if treatment is well tolerated. The reason for being less strongly recommended is that post-hoc data are only available and not data from randomized trials.